Sawasdee krab. Hi everybody. In these sessions, I'm talking about the pharmacogenomics testing to prevent the severe cutaneous surface drug reactions in Thailand. And I also would like to update you on health policy and also the clinical practices in our country. So out of my talk today, it is can be searched and read through this review article which published recently. I also take this opportunity to acknowledge all of my grant and also my collaborator for supporting me in pharmacogenomic research and some of the productivity from the pharmacogenomic research. It can be translated into the national policy and also incorporate into the clinical implementation right now. So in these sessions, I would like to focus on the current situations of pharmacogenomics and the precision medicine for prevention of severe cutaneous surface drug reactions. I'm going to talk briefly the pharmacogenomics of Thailand and update you the national health policy for pharmacogenetic screening tests to prevent the scar in our country. And lastly, the clinical implementations of the pharmacogenomics and the precision medicines in our setting we'll be sharing you today. So as you may have heard that Thailand has launched the mega project as a Genomics Thailand project. We would like to establish the whole genome sequencing database for 50K sample of Thai population, which can be recruited from 5 areas of the patients, such as the cancer genomics, rare diseases, and also the pregnancy women, non-communicable diseases, and the patient from the patients who infected of the infectious diseases, and also the patients who experience with the adverse effect of drugs in the pharmacogenomics area. We aim to use the genomics technology to drive in our healthcare systems in our country to take care of our people in the near future. So for the pharmacogenomics of Thailand, we aim to translate our knowledge from the research into the clinical implementations for 2 aspects. First one is the study for pharmacogenomic for drug dose adjustment, and the second one is to discover the biomarker for prevention of severe cutaneous surface drug reactions in our Thai populations. So in this figure, in this slide, here I have updated and summarized the pharmacogenetics biomarker that discovered from Thai populations. For here, as you may know that the HLA-B star 1502 has been announced to be the national policy screening before carbamazepine treatment. So it can be applied for selecting the oxcarbamazepine since the oxcarbamazepine share the risk biomarker with the carbamazepine as well. So in this year, the HLA-B 5801 has been launched as a latest national policy screening before the allopurinol treatment in our country. So moreover, after we already published the potential biomarker for cotamoxazole and dapsole, which is HLA-B star 1301. So we are now put our effort to propose this biomarker for screening of the carbamazepine and also dapsole for a policy decision maker by starting the cost effectiveness analysis first. So one of the key factors for the economic evaluations to convince the healthcare policymaker is the high frequency of risk and real in such populations. So from here, you may see that in our Thai populations, Thai is the high risk population for severe cutaneous adverse drug reactions, since we have a very high frequency of the risk and real for carbamazepine, allopurinol, dapsone, and also cotamoxazole. The high frequency is look very similar with the Southeast Asian community, since we have a high frequency of risk and real throughout the regions. So in Thailand, here is the template on the track that we already set up. If we would like to push our research finding into the clinical implementations as a national policy, we should starting from the first step for the retrospective study to discover and validate and confirm the association in the Thai population first, and then move into the next step for economic evaluations analysis, and then perform the prospective screening study as a pilot project. At the same time, develop the local or international guideline if possible. All the informations that we collected from all steps will be packaged to submit to the healthcare policymaker to consider and approve to be the national policy screening test. So the HLA-B 1502 is first biomarker that has been approved and announced for the screening in 2018 to prevent the scar in patients who are going to treat it with the carbamazepine in any indications. However, the serotype of 75, such as HLA-B 1521, should be considered for the clinical implementations in our populations. Moreover, the biomarker for carbamazepine has shown ethnic specificity, so therefore, in some setting, the HLA-A3101 genotyping have to be considered in some private hospital setting because in that hospital setting, they may take care of foreigner patients and sometimes they take care of mixed children, half Thai and also Japanese, Caucasians or Koreans as well. So in Thailand, therefore, we provide a variety of the testing for the screening of high-risk severe cutaneous adverse drug reaction, such as the carbamazepine in this figure. In the test that we can deliver with a different information levels to our physicians for making the decisions of their own patients. One is a specific biomarker screening, and the result can show here as a positive or negative. And the second is the HLA-B genotyping, which is the test that can be ruled out the carriers of the HLA-B serotype 75, such as HLA-B 1521. And also, lastly, we can provide the panels of HLA-A and HLA-B genotyping to serve for some mixed children and also foreigner patients such as Caucasian, Japanese, and Koreans in our countries. So, as you may already see by the table that I summarized previously, and in this table also show you here that almost of the pharmacogenetics biomarker for severe cutaneous adverse drug reactions are on the HLA-B genes. Therefore, from the HLA-B genotyping testing, it allows us to deliver the panel for interpretations and make the report as a panel predictions for our patients. So, as we know that the HLA gene is the germline genes, therefore they have no change whole life of the patients. So therefore the individual can genotype once in their lifetimes. From this concept, their data can be remained into the electronic medical record and it can be updated for the associations in some drug for the whole life of the individual to save them for the future drugs as well. So recently, in this year, the HLA-B 5801 is also incorporated into the national policy testing in the patients who are going to receive the allopurinol in Thailand, and the patients who are positive for HLA-B 5801, they should be avoided for allopurinol prescriptions, and the alternative choice can be febuxostat because the febuxostat is now integrated into the Thailand national drug list. So in the conditioning use category, so therefore, in the patients who are positive of HLA-B 5801, is a condition that physician can consider to prescribe febuxostat for their patients. So unfortunately, even we already set up the national policy screening for carbamazepine. However, as we learn from our experience, we have lost our Thai people, even like we already screened for that patients. So when we explore that events, we found that we lack of key things in the clinical practices, which are the key success for clinical implementations. One is the health professional awareness. Another one is no electronic medical record in that setting. And lastly, that in that setting, they have no clinic counseling system in that at that times. So right now, therefore, the electronic medical health record has been enhanced to set up in some setting to alert the doctor when they order the high-risk drugs such as abacavir, carbamazepine, and also allopurinol. Even the doctor have no awareness or knowledge. This alert system can help to pop up and alert them to order the pharmacogenetic testing before prescriptions prescribe the drug to prevent the adverse event in that patients. So, moreover, when the lab is already done, the pharmacogenomic result will be incorporated into the electronic medical record in the setting to alert and pop up the positive result for the physicians and also pharmacists. So the physician and pharmacists have to consider to avoid such a drug that have a high risk in that patients and select the alternative choice for safe in that patients too. According to the clinical counseling system, so the pharmacogenetic counseling system have been integrated into the precision medicine workflow as the pre-test counseling and also the post-test counseling, as I'm showing you here in this figure. And for the counseling system, it can be operated as a personal pharmacogenetic counseling. And in this opportunity, we can use this opportunity to deliver them the pharmacogenomic card and also the precision medicine report. And we also let them know their own risk and which drug that should be avoided for their future life. And also, currently, as the COVID-19 outbreak, and it is getting worse situations in our country, the telemedicine and also the telecounseling has been set up accordingly. So in this system, we can counseling remote for the patients who are in confidence to come to the hospital since they may scare the COVID-19 exposure. So as the Genomics Thailand is the national agenda, all related public health counselings such as pharmacy, medical doctor, dental doctor, nurse, and also the medical technology join together to prepare the human resource and develop the training course for a genetic counselor specifically for the pharmacogenomics. The Pharmacy Council of Thailand also prepared the training course for a pharmacist who will be in charge for pharmacogenomics in clinical implementations. As the lack of health professional awareness, we also provide the workshop, academic meeting, and also the conference to provide them the knowledge and enhance their awareness throughout the country. And in these figures, I show you here the 10 years data from my labs. So you may see that the number of requested pharmacogenetics testing screening for a severe cutaneous surface drug reactions has been increased year by year. And half of the request is from public hospital and another half is from private setting. And the most request of the pharmacogenetic testing is a HLA-B 5801 for allopurinol screening. However, in the real world, the patients may take care by several doctors and receive not just only one drug. So we are now implementing the panel pharmacogenetic testing in some hospital. And you may see how complicated in this policy from in this polypharmacy. And in sometimes the patient take care herbs which can interact and interfere the clinical outcome of the pharmacy in that patient. So therefore, we are now develop the clinical decision support tool for a complicated condition like this. So we are now move forward to the next step for a preemptive testing for the pharmacogenetic test in some setting using the next generation sequencing platform. And so you may see from this figure, this is an interface of the computer electronic medical record that show the pharmacogenetics result of some patients, and also the genetics pharmacogenetic variations has been shown in the pharmacogenetic course as well. So right now in Thailand, we are now in the phase of the genomics and pharmacogenomics driven healthcare system to minimize and to eradicate the adverse event like severe cutaneous adverse drug reactions for our Thai populations. So last but not least, I would like to take this opportunity to thank you for all members in the Pharmacogenomics Networking of Thailand. We push a lot of effort for the research and also the clinical implementations as I already shown you. And on behalf of the Pharmacogenomics of Thailand, I would like to thank you, Professor Elizabeth, Professor Bruce, and also the organizing committee for inviting me to share you our experience and knowledge in this meeting. So thank you very much for your attention.